Good day. Our topic for today will be Hansen's disease, or what we commonly know as leprosy. Hansen's disease is a chronic granulomatous infection affecting primarily the skin and the peripheral nerves. In ancient times, it is seen as a negative stigma. They say that this disease is incurable, mutilating, and contagious. WHO wanted Hansen's disease to be eliminated by the year 2000. In 2018, the WHO reported the prevalence rate to be zero point 0.2 per 10,000 people. The disease burden of leprosy was concentrated in India, Brazil, and Indonesia. In the Philippines, the DOH reported a prevalence rate of zero point 0.4 cases per 10,000 people in 2017. Mycobacterium leprae, which is the causative agent of Hansen's disease, is a non-culturable, gram-positive, slow-growing, obligate intracellular acid-fast bacillus. In the human body, there is a high yield of bacteria in areas with temperature lower than 37 degrees Celsius, commonly seen on the elbows and earlobes. In infected tissue, the bacillus favors intracellular location within the macrophages and the nerves. The mode of transmission remains controversial. Infectious droplet from nasal secretions of active multibacillary cases with nasal erosions were felt to cause the spread of the disease. Clearly, close contact is associated with acquiring the infection. Numerous genes have also been identified as possibly conferring susceptibility to infection with this bacteria. The latency period between the exposure and overt signs of the disease is usually 5 years for paucibacillary and up to 20 years for multibacillary. A diagnosis of leprosy must be considered in any patient presenting with neurologic and cutaneous lesions. Hansen's disease is diagnosed by the identification of the infectious organism in the affected tissue by skin or nerve biopsy using the Phyt-Faraco stain. In developing countries, slit skin smear is done. For bacterial load, you need to count how many organisms are seen per high power field, and with this, you can classify them as paucibacillary or multibacillary. The morphologic index checks whether the stain is good or poor. Dead bacteria will stain poorly, so it's possible that the medications have killed the bacteria, but the dead bacteria are still within the tissues. Normal individuals will usually produce a wheal and flare reaction in the histamine test, and this reaction is usually absent in Hansen's disease. In the methicillin sweat test, normal individuals will produce sweat, but there is anhidrosis or no sweat in Hansen's disease. Other tests includes serologic testing. In phenoglycolipid 1, which is present in the cell wall of the bacteria, you test for the antibodies against the phenoglycolipid 1. Polymerase chain reaction is used mostly for research purposes because it is not cost efficient. This serologic testing is useful only for multibacillary cases. Lepramin skin test is not diagnostic and only detects the immunologic status of the patient or the cell-mediated immunity of the patient. In many exposed patients, the infection apparently spontaneously clears and no clinical lesions develop. If skin disease does appear, the initial clinical lesion may be a single, hypopigmented patch, perhaps with slight anesthesia, and this is what we call indeterminate leprosy, most of which resolve spontaneously, but some can persist, and if it's diagnosed and treated early, it can be resolved. But if it's not treated, signs and symptoms of leprosy may develop. The spectrum of leprosy has two stable poles, the tuberculoid and lepromatous form. The polar tuberculoid form, which is a form of high cell-mediated immunity, is characterized by less than 5 lesions and very few or no organisms. Interferon gamma and interleukin-2 are the cytokines responsible for good cell-mediated immunity. The lepromatous pole has a very little cell-mediated immunity against the organism, and the lesions are numerous and may contain many organisms, known as multibacillary. Interleukin-4, 5, and 10 are the cytokines responsible for downregulation of the cell-mediated immunity and enhancement of the humoral immunity. Between these two poles are the borderline types, which usually are unstable. Downgrading is a process with a move usually from the tuberculoid type to the lepromatous pole. Leprosy may also involve only the nerves, and this is what we call a pure neural disease. First, we go to the early and indeterminate type. The onset is insidious. Usual first manifestation is numbness in 90% of patients, and years may elapse before skin lesions appear. The earliest sensory change is the loss of sensation of cold, followed by light touch. First lesion is usually a solitary, ill-defined hypopigmented macule, often seen on the cheeks, upper arms, thighs, and buttocks. Few cases remain in this form. Some may evolve into lepromatous or tuberculoid, sometimes on the borderline types. But more commonly, it often spontaneously resolves and never develops signs and symptoms of Hansen's disease. Next is the tuberculoid type. It presents with a single or few lesions, and typically, it shows large erythematous plaque with sharply defined and elevated border that slopes down to a flattened atrophic center, known as the saucer right side up. The presence of palpable induration and neurological findings distinguish it from indeterminate type of leprosy clinically. The surface of the lesions of the tuberculoid type can be very dry or scaly. It can also be anhydrotic. A tuberculoid lesion is usually anesthetic or hypoesthetic. Superficial peripheral nerves are enlarged proximal to the skin lesion. There is commonly no hair growth within the lesion. Acid-fast bacilli is negative in the lesions and nasal scrapings. Lepromin test is very positive, and nerve involvement is early and prominent. Because nerve involvement is early and prominent in the tuberculoid type of leprosy, it may lead to changes in the muscle group, like atrophy of interosseous muscles of the hands, wasting of the thenar and hypothenar eminences, contractures, facial paralysis, and foot drop. The evolution of the lesion is usually very slow. There is often spontaneous remission in about 3 years or sometimes sooner with treatment. Next is the borderline tuberculoid. This is similar to the tuberculoid type. The lesions are numerous and smaller. Characteristic lesion shows a satellite lesions around a large plaque or patch. Lepromin test is still positive. Next, we go to borderline leprosy. In borderline leprosy, it shows numerous, irregularly shaped, erythematous plaques that are often asymmetrical. The edges are not so well defined. Nerves may be thickened and tender, and anesthesia is moderate. Lepromin test is negative. Next, we go to borderline lepromatous. In the borderline lepromatous, it shows many lesions that are often symmetrical. It can consist of macules, papules, plaques, and nodules. Nerve involvement appears later. It may be enlarged, tender, or both. Sensation and sweating are normal. In this type, they do not show full-blown symptoms of lepromatous leprosy. Now we go to the stable form of leprosy, which is the lepromatous leprosy. Lepromatous leprosy may develop as such. Sometimes they may occur after indeterminate leprosy or can be a downgrade from borderline leprosy. It may present as small and numerous macules with irregularly defined borders. Lesions are often symmetrical. Lepromatous leprosy can also present with infiltrations. Diffuse infiltrations of the face, especially the forehead, with loss of eyebrows and a waxy shiny appearance of the skin, sometimes described as varnished, is seen in lepromatous leprosy. A plaque type of infiltration can also be a presentation. The infiltrations may also be manifested by development of nodules called lepromas. These are early nodules that are ill-defined, mostly on the apical parts, such as the ears, brows, nose, chin, elbows, hands, buttocks, and the knees. In lepromatous leprosy, bacilli or the acid-fast bacilli in the lesions are very many. Lepromin test is negative. There is slow progressive loss of hair from the outer third of the eyebrows, termed as madarosis. Then, there will be loss of eyelashes, and finally, body hair. But scalp hair is unaffected. The hallmark of leprosy is nerve involvement. There is usually anesthesia within the lesions in the possibacillary and borderline type. And in the lepromatous type, it often presents as progressive stocking glove peripheral neuropathy. In the tuberculoid type, there is asymmetrical nerve enlargement localized to the skin lesion. This is caused by inflammatory infiltrate in the nerves. In the lepromatous type, there is symmetric nerve involvement, usually not associated with skin lesion, and this is caused by massive bacillary infiltration with compression and eventual fibrosis. The neuropathy is termed primary impairments. Secondary impairments are consequences of neuropathies, and they may manifest as wounds, clawing of digits, contractures, and shortening of digits. These are commonly seen in multibacillary cases. Neuropathies may progress even after effective multidrug treatment, and these impairments may continue to appear for many years. Corneal erosion, keratitis, and ulceration may result from involvement of the facial nerve. Blindness may occur in 2 to 4% of cases. Mucous membrane may also be involved. Nasal infiltrations and nodules are often seen. Perforation of the nasal septum causing saddle nose deformity can also be noted in lepromatous leprosy. There can also be nasal congestion and hoarseness. In lepromatous leprosy, the body is diffusely involved, causing bacteremia. Most heavily affected are the lymph nodes, bone marrow, liver, spleen, and testicles. What if you have Hansen's disease and then you get pregnant? Pregnancy is a state of relative immunosuppression. and so pregnancy may lead to exacerbation or reactivation after apparent cure. Pregnancy may also produce reactional states, but you still have to take the multi-drug therapy. But one must avoid thalidomide, ofloxacin, and minocycline. How about if you have Hansen's disease and then you're HIV positive? In HIV, there is profound immunosuppression of the cell-mediated immunity. But surprisingly, it does not seem to adversely affect the course of Hansen's disease. Some reports just extend the treatment of the multi-drug therapy. Reactional states can occur if used together with antiretroviral medications. Now we go to the reactional states. 50% of patients will experience a reaction after institution of antibiotics. Some reactions may be caused by intercurrent treatment, some with vaccination, pregnancy, taking of vitamin A, and bromides. It may be severe enough to cause permanent nerve damage. But even if with reaction, you must not stop taking the multi-drug treatment. Type 1 reaction is often due to enhanced cell-mediated immune response to Mycobacterium leprae. This type of reaction sometimes occurs when treatment is started. If the reaction occurs with the antibiotic therapy, it is called reversal reaction. And if they occur if the pole changes from borderline to a severe lepromatous, it is called downgrading. This type is mostly severe in the borderline lepromatous type. In type 1 reaction, there can be inflammation of existing lesions. There is usually no systemic symptoms. Lesions swell, sometimes simulating cellulitis. The reaction may lead to loss of nerve function and permanent damage to the nerve, which makes it an emergency. Next is the type 2 reaction, or the erythema nodosum leprosum. This occurs in half of patients with borderline lepromatous or lepromatous leprosy, most of the time within a few years of institution of antibiotic treatment for Hansen's disease or during pregnancy. ENL is a circulating immune complex mediated disease. It is multisystem, affecting the eyes, kidney, liver, spleen, and other organ. It presents as erythematous subcutaneous and dermal nodules that do not occur at sites of existing lesions. An uncommon and unusual reaction in patients with diffuse lepromatous of the Labonita type is known as Lucio phenomenon. It presents as purpuric macules that evolve to bullous lesions that rapidly ulcerate, especially below the knees. Now we go to treatment. Before, dapsone monotherapy was the standard treatment for Hansen's disease. But due to resistance, multi-drug therapy is now used, which includes rifampicin and clofazimine. Dapsone is bacteriostatic. Side effect includes exfoliative dermatitis, hepatitis, neuropathy, and granulocytosis. Rifampicin is highly bactericidal for Mycobacterium leprae, but to avoid resistance, it is not given as monotherapy. Clofazimine is both bacteriostatic and also has an anti-inflammatory effect. Side effect includes discoloration of the lesion when exposed to light. WHO recommends 6 months duration of the multi-drug treatment in paucibacillary type. Usually give monthly supervised rifampicin at 600 mg and daily unsupervised dapsone at 100 mg. Follow-up is a minimum of 2 years with clinical examination every 6 months. For multibacillary cases, WHO recommends at least 1 year of treatment, but in some countries they can extend it up to 2 years or until there is negative slit skin smear. We usually give monthly supervised rifampicin at 600 mg and clofazimine at 300 mg, and daily unsupervised dapsone at 100 mg and clofazimine at 50 mg. Follow-up is a minimum of 5 years with clinical and bacteriologic exam at least every 12 months. WHO recommends 1 year of multi-drug treatment, but there are concerns of increased number of relapses. For single lesion paucibacillary disease, one can give a single dose of rifampicin at 600 mg, ofloxacin at 400 mg, and minocycline at 100 mg. Adjunctive treatment includes occupational therapy that includes training on how to avoid injury to insensitive skin of hands and feet, using of special shoes, and ophthalmologic intervention. Remember, standard multi-drug treatment is very safe and effective. Multi-drug treatment is available for free in most health centers. WHO recommends 6 months of treatment for paucibacillary case, 12 months for multibacillary case, and 1 dose rifampicin, ofloxacin, and minocycline for single lesion paucibacillary. Vaccine is still said to be in development. BCG provides at least 34% of protection. To prevent transmission, we must always treat active multibacillary patients. And in hyperendemic areas, we need to do physical examination to exposed individuals. A trial of once-a-year ROM is also advocated in hyperendemic areas. Hopefully, in the upcoming years, the Philippines will be Hansen's disease free. Thank you for listening.